Where'd it go?
Came from a long time. Came from Afghanistan now already. Yeah.
We were sitting at the back of the car yesterday. We were coming back from the shops and Joanne said, "Can you hear what he's saying?" And she said, "It's not truck." Where has he picked that?
Okay, we're ready to go? Yes, okay. Welcome everyone to the Research Education Program seminar today. Can I just ask people, we're getting a bit of feedback here, just please can you make sure you're on mute for you who've joined? Yes, okay, that sounds great. It's my pleasure to welcome Gary Geelhoed to speak to us today to tell us about the WA Health Translation Network and the role that they've played in coordinating research in the current pandemic. Gary is not a stranger to those of us in paediatrics, having previously been head of the emergency department here as well as chair of the Clinical Staff Association and more recently Chief Medical Officer before taking up the Executive Director position at the WA Health Translation Network. And I think one of the strengths of the WA Health Translation Network is really during this pandemic has been able to bring together the health service providers with research institutes, universities and other researchers to really try and maximise the coordination of research that's been happening across WA. So Gary's going to talk to us today. Are you okay, Gary?
Yeah, I was just trying to turn the sound down on that thing, but that's fine.
We will get rid of that laptop. Yeah. So I'll hand over to Gary. He's not going to have any slides. He's going to talk to us about the next 20 minutes and they'll be happy to take some questions.
Thanks Peter. And as always, it's good to be back in the Children's Hospital, although it's a different one to the one I worked in for many years. So welcome to people here and also everyone online. So I've been asked to speak for about 20 minutes just about, from my point of view, what's happened with the response to COVID-19 on Western Australia and on the, specifically the medical research community. So I'll just briefly talk about the role of the WHTN, so why we might be getting involved, and then I'll talk about the actual response. And apologies for those who've heard this many times before, but the brief history of the WHTN is probably came from the McKeon report. McKeon was asked to look at medical research in Australia a little less than a decade ago. Basically made many recommendations, but one of the key ones was that we should create so-called RTECs, or they're called Advanced Research Translational centres, and this was based on the experience, successful experience in North America and Europe, especially in England, and where essentially, groups came together with the idea that if you combine clinical service with academia and research and brought them together and had better cooperation, you got better patient outcomes, and that's clearly what those three groups are all about. So, based on that, the NHMRC, or based on the McKeon's recommendations, NHMRC put out a invitation for these centres to be recognised. There's now 10 of these centres around Australia. There's been 3 rounds, if you like. 4 were recognised in the first round. WA, we all got together and put together a group, and we were told come back in 2 years or something. We did, and we were successful, mainly because the first time we were saying this is what we want to do, and 2 years later we were able to say this is what we are actually doing. So there's no template for these things, but as a general rule, each of these groups has hospitals, has medical research institutes, and it has universities. So here in Western Australia, we're very comprehensive in that we have 6 research institutes, Telephone Cares, Mary Perkins, as well as the 5 universities, hospitals, private hospitals, as well as the health department and the and Path West, and so. Together, these 9 centres around Australia formed the Australian Health Research Alliance, and they have a number of national initiatives, and in WA we're co-leading two of those, one around wound care and one around consumer involvement in community and consumer involvement in research. So that's the history. Now, I would point out NHMRC put out the call and recognised us, but there was absolutely no funding. But subsequently, if you remember, that NHMRC's funded a little less than $1 billion a year for many years, medical research in Australia. But the new Medical Research Future Fund, the MRIF, that came online some years ago, and subsequently they've funded these centres to do certain things. So we've received roughly about $6.5 million from MRIF. And through that, some of you may know, we've set up early career fellowships, and we gave $3 million to the area health services, including CAHS, of course, as WACS as well, to come up with research translational projects and so on. So that's the sort of the background, and the philosophy, I think, early on. Now, I've been involved for 2 years, but prior to that, when I was at the health department, I was very much helping set up this whole system, as well as being in the board and so on. And the whole idea was to research translation, that is to bring down this mythical 17 years where something is published and when it becomes standard, standard practice. 17 years is a long time to bring that down. But also the idea of adding value. We don't have a lot of resources, but compared to say UWA or some of our big partners, but the ability to bring everyone together and make a greater sum than the parts. The idea was that any young health professional in WA who wants to step up and do research as well, that we would provide support in different ways. So the various platforms that we have, hopefully you know of some of these, but they include we have the Science on the Swan meeting, which has been postponed for a year, of course. It's been going for 5 years. Everyone comes together, and we feel like a research community here in WA. We have the Consumer and Community Health Research Network. Again, that's a strength in WA here, largely set up by Anne McKenzie years ago, who works at Telethon Kids still in this area. We have a clinical trials and data group under Chris Reed out at the Curtin University, and we also have a medical sort of research and education training program for online modules and so on, and you can find it all on our website. This is the page around COVID-19, but if you go to the website you can find all these things. And so we've also been involved with certain other things, trying to promote biobanking, trying to promote research imaging and so on. So these sorts of things that will help across the board, where no other group sort of is really, is set up to do that. So that's the sort of background. So when COVID-19 came, I'm not going to spend much time talking about that. You only have to turn on the telly and you're blasted with more information than you'll ever need about COVID-19. But so basically everyone wanted to do something at that stage, and luckily, Australia's done very well and the situation's changed. But, we were expecting this so-called tsunami of patients, we really thought. And it was a real risk. I mean, you only have to look at New York or in northern Italy or UK to know if you didn't quite get it right, how could this, could really get away. And so, because of our role and very broad membership, we were asked by the Roger Cook, the Minister for Health, and the Health Department to help coordinate this response. In the first instance, what we did was just, say to people, look, what do you reckon? We set up a meeting at really quite short notice, so I was worried about how many people we might get online, and of course it was online, and there were close to, or may have been just over 50 people at that first meeting. And again, it just underlines how we're changing things, like here today, a few of you here, many of you out there in cyberspace somewhere. And then subsequently, we've had weekly meetings since then of all these groups, and there's been this tremendous sense of a community working together, and we also had some money to spend. There's nothing like money to bring people together and get that warm and fuzzy feeling. Also formed a smaller executive that would meet once a week as well to help guide us. As shown up here, we had a website already, a dedicated website, which has been very useful to put all sorts of resources up there, and people could collaborate and see what else everyone else was doing. We also had a guiding document that just looked at what we were doing, all the different strands and so on, and that's been like both a guiding document, but it's also a record really of what we've done over the last couple of months. And again, you can find this on the website. An earlier initiative, and a lot of the things that have been done were things that are already sort of in the pipeline, but they've really been accentuated and supported because of that. And so some of you may know of Toby Richards. He's a vascular surgeon down in SMARS, and so he was working setting up a clinical trials unit. Now, there was different layers to this, but assuming at that stage we were going to get these huge numbers of patients coming through with COVID-19, that seemed a really logical way to be able to standardise things and make it as efficient as possible. So the sort of things that we helped set up was using a standardised protocol, and a lot of things were available that were set up just for pandemics because of experience in the past with MERS and SARS and various others. So for instance, the CAHS protocol, where when you consent patients, standardising that when patients come in, they could agree to, if they're having samples taken, usually blood, that some of that could go to research, or they might consent to actually have samples taken for research exclusively, or they would consent to being approached to go into clinical trials. So that was all put in place. Data's everything these days, and so a big effort was made to standardise how we collected that, and using the REDCap system, which is fairly uniform now through the system. Again, the ability so that you're speaking the same language, but you can also, there's different data sets can talk to each other as we go forward. And biobanking, which again WHTN was already involved with. We'd done some work earlier with testing a sort of an open source software called Open Specimen with the Origin study in Joondalup and at Telethon Kids. That was very successful, so again we were able to use some resources that became available to hire people to do that properly, even buy a few freezers, increase the capacity, and again make that a sort of a virtual biobank for WA. And while I mentioned that Toby Richards kicked off a lot of this in the south, I mean, this is very much, again, a collaboration, so that the directors of research through the different area health services, Erin Chakira just over the road, and Graham Hillis in the east, and because it was mainly going to be around adult medicine at that stage, they were the key players. But Peter here also involved, and also the folks in WACS. We also set up. So that was mainly about hospital patients, but we also then helped set up Chris Reed out at Curtin, if you remember, the Clinical Data and Trials Centre. He had a study called Civic, and I won't go through, but basically it was more around cardiovascular stuff. That was his interest, but that was able to be enhanced and supported to look at all sorts of things in the community. And it's become clear that, of course, it's not only the effects of the virus on people's health individually and collectively, but it's also the effect of this incredible social experiment where we're all being locked down, for the last couple of months, and the impact of that as well. And so Chris's group, we were able to support them to set up various subgroups around mental health, around to some extent Aboriginal health, or in child adolescent health and so on, and these different groups. So they're all been working as well, and all these people talking to each other and collaborating. An early, which turned out not to be as important as we thought, but an early emphasis was to support existing trials. And I must admit, this became as a surprise to me, but there were trials that actually already existed that were set up specifically for pandemics, and specifically the REDCap MAP trial you might have heard, REDCap MAP trial that you might have heard of, REDCap MAP trial. Basically, that's for people with really severe viral, pneumonia. Now, that was already existing, getting the occasional patient as we come through flu or something like that. But clearly, that was the one that was going to be important. Now, There's no treatment at this stage really for COVID-19. You can support people, you can up to the time that you put them on a ventilator and so on, but then, you know, it's in the lap of the gods. But through REDMAP CAP trial, that gave the ability, and it's a so-called platform trial, you know, meaning an adaptive trial. You can keep trialling different sorts of treatments and antiviral treatments, whatever. And if one is works, if you had really big numbers, and this trial is not just in Perth, of course, it's through Australia and the rest of the world. And as things come through, you can test these things, and then after a certain time, you can see it's significantly either good or bad. If it's no good, you get rid of it, you try something else. Now, why that was important, we thought, to emphasise here in WA, because that was the only way that West Australians were really going to be able to access potentially effective treatments. And so that was one of the lines we kept pushing when we're talking to philanthropists and people about all the work we're doing. Now, as it turns out, it's a great problem to have for researchers that there's just not enough cases around it at the moment. There's also the ASCOT trial, which is something similar, but it was more for patients who weren't quite as sick but already in hospitals and so on. And then in different ways also, we were aware of and make sure it was coordinated and trials that have been done and initiated in this building. So the so-called BRACE trial, and many people here would know about it because you're probably part of it, and that was looking at BCG, the old inoculation for tuberculosis. It's got general immunological properties and helpful in different circumstances, so that's being trialled here to see if it'll protect healthcare workers, and of course if it's helping or protecting healthcare workers, it can help everyone. So that's sort of all set up, fantastic recruitment to that trial, but again, no COVID-19 or very, very little at the moment. And also another one, the Telethon Kids, the COCO trial, where basically that's all about if there's, as we go forward, I think the analogy with bushfires is very good. You know, with bushfires, if you have little spot fires and sparks, if you keep putting them out, you don't get this huge, conflagration, and that's exactly what we need to do. As society starts, we start mixing again with people, going to restaurants, etc., no doubt, and more probably importantly, we start to bring in people from either over east or from overseas. We are going to get this happening. And why the COCO trial is important is because it allows people who have been exposed to these folks to then be trialled for, again, different antiviral treatments to see whether it's going to decrease the viral load, decrease people infecting others. So now the other thing that happened was that the Department of Health, again, I worked there for 3 years, and it works very well in many ways, but it is a bureaucracy. It can be slow to get things going, so they trusted us to give us $3 million to get things going. And we divided that up into clinical trials where we had people apply for money. We had over 84 applications. Sadly, of course, we couldn't fund all of those, but we had an independent tribunal. Peter was part of it, and we allocated that money. But more importantly, in some ways that was an old-fashioned way of doing things, but more importantly, I think the money that we had for infrastructure, we were able to, taking advice from across the board and with everyone collaborating, actually invest that in things that I think are going to be are very useful now for clinical trials, and as we go forward, if we get these numbers coming up to some extent with COVID-19, but a real investment in the future, putting that infrastructure in place. So this is not just good for COVID-19, it's fantastic for WA research going forward generally. And so we did that in a different sort of way, because the health department were proposing, and almost certainly would have put out a call, and people would have then applied for infrastructure for small trials, etc., and that would have all been handed out, and hopefully did some good work, but at the end of it all, probably you don't have a greater sum than the parts. While what I think we've done, supporting the biobanking and the clinical trials unit and so on, and the civic group, I think that's something that will have a lasting legacy. In terms of funding, we sort of come up with a concept of an overall plan of what we wanted to fund that everyone could sign up to, but sort of siloed funding, as it were, because, for instance, the foundations, or the Spinnaker in the south, and the Charlie's Foundation on this campus, and the Royal Perth Hospital Foundation, they all wanted to help and contribute, but they're constrained about how they can spend their money, where they can spend it and so on. But they were happy to then say, okay, well, what part of the plan are you going to, is applicable to our hospital, and we will help fund that. So for instance, I mentioned that the stuff that Toby was setting up in the south, this was with all the directors of research across the area health services, and so some of the foundations, they will fund some of the support staff we put into, to do those trials. And what we're setting up is something that will be much more efficient. So if someone has an idea now, they hopefully don't have to fund the whole thing right from scratch, but they can actually set it on top of these networks that and platforms we've set up, and they'll be much more efficient. They'll be much more uniform in lots of ways, so the data can speak to each other, etc. But also, a much more, a much more efficient system. What's happening now, of course, is we have the flattening of the curve, which is a wonderful thing, not good for researchers, but wonderful for society. And of course, Australia, I don't know of any country that has done better than Australia. We're in a situation now, it's interesting that COVID-19 came a bit later to Australia. It gave us a bit more time to organise ourselves, the things that really help. But in some ways, we're coming out of this now much faster because our curve is so much, smaller. And so while we were sort of following other people, and there's huge numbers of patients going into clinical trials elsewhere who sadly are, infected with COVID-19 and very, very sick. Ones like the remap cap I mentioned and so on, which hopefully will be, giving answers at some stage and better ways to treat these patients. But we're in the stage now where we're navigating our way out of this, and so maybe we can really, if not lead the world, certainly give some suggestions how you might do this better. So our focus now is a bit more about that, all the questions that haven't been answered as yet about, can you be reinfected with COVID-19? What does immunity mean? What tests should you be using, for instance? And so our focus is now going to be on that. Now again, because of this wonderful sort of collaboration we've had across the board, a whole group of immunologists from right across the universities, the hospitals, etc., have all come together and are coming up with the sorts of things we should be looking at. So rather than maybe at the start of this, when it was all a bit rushed and we just put out a plan for research proposals, then we've got all these separate ones, which to some extent we tried to combine where we could. But so hopefully this is a much more collaborative, sensible approach. I think it must be said too that you can never predict these things. I think very early on people made a lot of decisions and jumped in fast, and that's not a bad thing. I mean, I think inaction would have been terrible then. But now, of course, because everyone acted so fast, to some extent we're now, not repenting, but now adjusting to that. The other thing that's happened is, of course, the government quite quickly then tried to build up all its stores and its PPE, etc., but also the ability to test, which I think is, most people agree, looking at what's happened across the world, the ability to do very wide testing is the key to it, putting out those spot fires. But now we don't have much need for testing, like just getting the contacts and then testing around them. And so the government now is working with various groups, and they've come up with this term DETECT, and again I won't bore you with the acronym, but looking at specific groups and trying to get a clearer idea of what it means in our community and how we best navigate our way out of this strange situation we find ourselves in. So different groups are taking different leads. So for instance, Telethon Kids is doing it, not surprising, around school children and schools. And there's another one around FIFO workers, which again, at the moment, to have our mining industries closed down because of COVID-19, of course, would be a disaster for the country. And so that's another group. We're also looking at healthcare workers, specifically as a little microcosm, the emergency health workers at Royal Perth Hospital, but also paramedics, etc. So that's a whole group of sort of very widespread community work that's being done as well at the moment. Look, that's the sort of the Cook's tour really of as I see it and how we've responded. Just a few things. I must say, you know, I mentioned ARA, this alliance. We're in the 10 groups around Australia. We've been lucky here because we've got a fairly good relationship with, you know, at the Department of Health and the Minister for Health, which doesn't happen in all the states. And of course, the other thing is we're just the one network here, so that we're sort of quite comprehensive. But you know, there are 2 in Victoria, 3 in New South Wales, now 2 in Queensland, 1 in South Australia. And talking to them, I know because they don't have that relationship with government and the Department of Health, they certainly didn't get any funding at this stage from any of those people. That they've sort of contributed like everyone else, but we've really sort of led the way here. So much so when you're talking on these link-ups, they talk about the WA model, you know, sort of, you know, as an ideal. And it's not been perfect, but the collaboration we've seen, I think, is fantastic. I think the challenge now is how do we take that going forward? There's no doubt, A, having money, and B, all focusing on the one problem is a great way to bring people together. But having said that, we going forward, we should sort of take note of this model and see how we can best help it. One other thing I didn't mention in passing, but again, a great example of collaboration among all the WHTN partners a few years ago was to set up the Australian National Phenome Centre that you probably know of, based down in Smars or in Murdoch University. And again, that is a really world-class unit, and basically it looks at biological patterning. I mean, I won't go through this, but basically that has the ability to sort of look at biological samples and not just say, yes, you have COVID-19, or at least this is the promise, not that you're infected or you're not infected, but maybe you can say, but this person, because of the biological patterning you can do on the samples of that, can actually say, but this person really is at risk of dying perhaps, and these people almost certainly are going to be, just get the mild cold that, you know, some people get, or very few symptoms. And again, that was a great example of WA all coming together, collaborating and seeing the very positive outcome from that. And so they are, you know, working with people over east, but also with Imperial College in London, and I think Cambridge, and ones in the United States as well. It's a worldwide network. WA is at the centre of that, really, because we managed to lure Jeremy Nicholson and Elaine Holmes from the Imperial College London to here. And again, they're not constrained by numbers because they're getting samples coming from all these other centres. So again, the things we set up, the biobanking, the clinical trials unit, the ANPC, all those things which existed already have just sort of, you know, shown their worth during this, this difficult time. So I think that might just be about 20 minutes. So hopefully there will be a lasting legacy. It's been a terrible time, but I think there's some positives come out of it. It's shown the value of the WHTN, and also I think, you know, on a personal level, you know, so many, you know, the way people live their lives and so on, and the way we communicate is hopefully is going to change for, you know, positive as well going forward. Thanks, Peter.
Thanks, Gary. We've got time for some questions. Is there any in the audience or comments? People talking about meetings. No question. I mean, Gary, do you think this is a model going forward for any research that we do in this state? Do you think this is a better model for how we use our research funds to support research? Yeah,
look, absolutely, because you know, you become aware that everyone's trying to reinvent the wheel, or trying to, not reinvent, but invent the wheel, you know, across the system and that. And even just during this process, you know, we become aware of different groups doing different things, and we've been able to, you know, put them together. And you know, the whole rationale for the WHTN was to try and make it more efficient and bring people together, and as I say, ultimately get better health outcomes. But if we're going to be competing on the national stage as well, we need to be thinking about how we present ourselves to internationally and nationally, and not just you know, if you like, you know, having all the silos here. Having said that, I mean, as I mentioned, we don't have a lot of resources in the network. And UWA, and just to mention a few, and the Harry Perkins, and certainly the Area Health Service, they're huge multi-billion-dollar, you know, businesses. But if we can bring everyone together and get a greater sum than the parts, then I think that's, that's how it'll work. All of those groups will continue, as they've done through the COVID-19 thing, they'll continue to do their own things. But where we can combine and bring people together, I think there's huge potential. As it turns out, WHTN is sort of going through a period of looking at ourselves, our governance structure, how we work, what our priorities are going to be, and that's all been put on hold, of course, because of COVID-19. But what's happened during this this crisis, if you like, I think will really influence the final answers that we come up with. And in some ways, we've been around for a number of years and slowly getting some recognition and adding value. But I think in some ways this has sort of advanced our cause maybe, 5 years or something, where people have just realised the advantages of working together, of collaborating.
Gary, one question is, are there any plans or studies that will look at serology for antibodies?
Sorry, I didn't catch it.
Are there any plans to look at serology for antibodies within the WH Translation Network?
Yeah, well, not within us as such. We're basically trying to coordinate that. But that I mentioned this whole group of immunologists. That's exactly what they'll be wanting to do. About what tests you need, what the timing of these things, and so on. Answering some of those fundamental questions. So now the challenge will be, of course, to get some funding for them. We hope that'll come through. But yes, absolutely, that's the focus now. Yeah.
So that'll be for both diagnostic testing, I guess, but also population levels of immunity and how long that lasts for. Yeah. Good, thank you. Are there any other questions? Can't see anything up there. There we go. This will be recorded, so it will be on the Research Education website and CAHS. So please, if you have people who weren't able to make it today, please they can search it. And it'll just leave me to thank Gary for coming to tell us about the great work he's doing. And certainly we would like to continue to hear maybe in the future. Thanks, Gary.
Yep. Thanks, Peter. Thanks, everyone. Bye-bye.
Okay. Thank you, everyone. Excellent. That was great.
Oh, thanks.
No, that's perfect.